Aloha, everyone. My name is Lynette Gaylord. I am the president of ARCA, Alliance of Residential Care Administrators. This CME activity is jointly provided by the Queens Medical Center and UH-JABSOM Department of Geriatric Medicine. Joining me this afternoon is our interdisciplinary geriatric echo hub team, which includes our advanced practice nurse, Courtney Nunokawa, psychologist Lucas Morgan, pharmacist Reese Ueno, physical therapist Susie Neufeld, and geriatrician Ritabel Fernandez. That's Dr. Ritabel Fernandez. We're excited to share our collective experience and wisdom and learn alongside you. As a reminder, evaluations are required for CMEs. You can find evaluations by following the link in the chat or at any time on our website and email advertisement. We offer continuing medical education for MDS, DOS, RNs, APRNs, and physician assistants. We also offer NASW CES for social workers and certificates of attendance for CNAs and students. NASW credits will be sent out monthly, and CME records will be sent out by Queens by mid-January. Your comments are very important and useful to the planning committee for future programs. This ECHO webinar is a forum for mutual teaching and learning from experts and each of us on the front lines. As the ECHO motto goes, all teach, all learn. In the spirit of aloha, we encourage you to turn on your cameras to help us build a community of learning. Feel free to eat during this ECHO session. Good nutrition is the key to a healthy lifestyle. Our ECHO webinar format consists of the following: a short lecture from our presenter, open comments from the expertise of the ECHO Hub team, attendees' comments, questions, and examples of case discussions. Additionally, we invite you to share any geriatric cases. Lastly, please keep discussions HIPAA compliant. This includes not sharing the patient's name, birthday, address, etc. We learn best from our patients and or clients. They are our best teachers. Our distinguished speaker today is Dr. Chad Kawakami. Dr. Kawakami is from Oahu and graduated from Oregon State University with his Pharm.D degree. After graduation, Dr. Kawakami completed a PGY-1 residency at the Queens Medical Center. Following residency, he worked as a clinical pharmacist at the Queens Medical Center, Tripler Army Medical Center, and the Department of Veterans Affairs Pacific Islands Healthcare System. He is currently an assistant professor of pharmacy practice at the Daniel K. Inouye College of Pharmacy, specializing in geriatric pharmacotherapy. He maintains a clinical practice at Pilimomi Medical Center, where he is aligned with the John A. Burns School of Medicine Family Practice Residency Program. He is board certified in pharmacotherapy. Dr. Kawakami is also Lieutenant Colonel in the United States Army Reserve with 16 years of service. He is the commander of HHD 1984th United States Army Hospital, Pacific, and will attend Army War College in the summer to pursue a master's in strategic studies. Please give a warm welcome to Dr. Chad Kawakami.
Hey, thank you so much. Thank you so much for that warm introduction. So today I just kind of want to we're gonna go over some stuff. Let me just change over my screen here so that everybody can see what the presentation is about. So I can see all of you guys. That's perfect. Hey, want to keep this very conversational. So if at any time in the presentation there's something that requires, you want me to clarify or explain a little bit more, don't hesitate. I cannot see if you raise your hand, so just unmute yourself and just jump on in. It's okay to just cut me off. That's fine. Because I want to make sure that we keep this conversational. So today we're going to talk to you guys about medications. And we're going to look at it through the lens of the 4Ms. And I'll talk to you a little bit about what that 4Ms is. So without further ado, we'll just go ahead and we'll go ahead and get started. So here's the learning objectives today. We want to be able to identify what are the 4Ms. Where does the 4Ms come to play in caring for your patients? Also introduce the concept of what matters and how medication should be incorporated into what is called an age-friendly care plan. And how do we apply the concept of quote unquote medications into a clinical case? Like how does all of this framework come together to provide optimal care for our patients? So let's put the four M's into practice and let's focus on medications. So in terms of medications, so the four M's, just to kind of reiterate, what are the four M's? The four M's is a framework that was put together by the Hartford Foundation and the Institute on Healthcare, the IHI. And the four M's include number one, what matters. So, what matters most to your patients? Number two is medications. So that's what we're talking about today. And the other third and fourth M is mentation. So when we pick medications, we want to make sure that the medications that we choose do not affect your patient's ability to think, their cognitive ability, and we also don't want it to affect the final M, which is mobility. So how do we as pharmacists and as practitioners, how do we obtain what's important in terms of medications from our patients? So to get a better understanding of your patient's medications and how they feel about it, here are some questions that you can ask them. So think about like what medications do you currently take? What times of the day do you take it? When do you take it? What other medications are you on, like inhalers, drops, or creams? Ask them about side effects. What kind of side effects, good or bad, are you experiencing? Do you ever forget to take your medications? And does any of these medications that you take seem to get in the way of what's important to you? So an example would be, maybe a medication that a patient is taking makes them really drowsy and it makes them sleepy all the time. And being sleepy is no way to enjoy life. It's a nice day, it's a beautiful day outside, and maybe you want to go outside and spend with your grandkids, chase them around the yard for a little bit, but you're so sleepy and you're not able to do that, and therefore you can't enjoy time with your family and your kids. That could really get in the way of what matters to your patient. So the bottom line here is if there's one thing to take away from this presentation, it's going to be this statement. In general, we don't like to use medications because medications have side effects, but sometimes medications are necessary. And so if a medication is necessary, we want to use age-friendly medications. And I'll go into what age-friendly what age-friendly medications might be or which may not be age-friendly. But you want to use medications that do not interfere with the things that matter to your patients, and certainly things that don't affect their ability to move and to think. And we want to do this across all of our care settings to include the care homes. So medications should be an assessment of the medications should be incorporated into each patient's plan of care. It should be part of how are we going to care for this patient? And so we want to make sure that we review for high-risk medications. So being able to identify some potentially dangerous, potentially inappropriate medications, be able to identify that and maybe even document it so that you can bring that to the attention of the patient's provider. And as clinicians, as providers and clinicians, things that we do when we identify these high-risk medications is number one, we can work to get rid of that medication through whether we stop it, deprescribe it, maybe we can readjust the dose, or maybe avoiding those medications altogether. So what are those high-risk medications? So here are some medication classes that I'll kind of go through, but I'll give you examples of each within each of these classes so that it can kind of provide a framework. So your benzodiazepines. Benzodiazepines are drugs it's like lorazepam. Ativan is the brand name. Valium or diazepam. Those are some medications. Those are some benzodiazepines that are really not good for our seniors. Opioids like morphine, for example. Many pain medications, morphine, hydrocodone, codeine, for example, those medications can really cause drowsiness, dizziness, and confusion in many of our patients. And again, those medications causing drowsiness and dizziness and can also cause confusion as well, affecting their mentation. Other medications like um, antihistamines, for example, like Benadryl. Benadryl is a very dangerous medication for our elderly because it can cause sleepiness. It also can cause dry mouth and confusion and falls. There are other over-the-counter prescriptions like sleepers you see on the on TV from time to time. You might have heard of Zolpidem, Lunesta, all of those sleeping medications. While it looks good, everybody wants a good night's sleep. And sometimes, it's normal for us to not have a good night's sleep every night. Um, but it's very important to really be careful of these sleeping medications because they can have very unwanted side effects. There are other antipsychotics and some antidepressant medications and even muscle relaxants, things for, a sore lower back that can also be very dangerous for our elderly. So these are some of the medications that we should look for when we were taking care of our patients. So if you just so happen to notice that, hey, what if my patient is on one of these medications? What do I do? So if you see that the older adult is taking one or more of these medications, it's important to discuss your concerns, and maybe even ask the patient what concerns they might have, and bring that up to the prescriber, so that they can take a look at it and maybe do a little bit of an assessment as far as what needs to be done regarding that medication. So you might be thinking, okay, well, you just told me that some of these medications are bad. What can I do to help incorporate these concepts of, identifying the medication? How can I incorporate this into the plan of care? So just remember that these medications, either individually or sometimes in combination, can interfere with the four M's. That is, that it can interfere with what matters, mentation and mobility. It can cause them to be confused, delirious, and fall. So within that, when you identify these, bring it up to your care, bring it up to the pharmacist. You can bring it up to the prescriber so that we can consider deprescribing. Deprescribing includes a dose reduction and eventually perhaps medication discontinuation. We can also assess for polypharmacy. Polypharmacy is when the patient has too many drugs. Like some of your patients may have like two or three drugs. You might be lucky, but many patients have way more than nine medications. The more medications that the patient is on, the more chances that there is a drug-drug interaction or a drug-food interaction. And so an assessment of that of medication use by your pharmacist may be a good start, a good place to start. It's also good to have a thorough review of the medications upon admission to your care home, and at least once per stay. We cannot assume that all medications should be sustained. For example, sometimes a patient coming in from the hospital may be on medications that should have been stopped immediately after discharge and was not meant to be continued. So a thorough assessment of, okay, these are the patient's medications. Do we really need these medications moving forward is going to be very helpful towards ensuring that a medication is not kept on for longer than it was originally intended. Also, we should assess our medications daily, especially if there is a condition that is relatively new or maybe the patient is a little bit unstable. For example, if a patient has diabetes and their blood sugars are a little bit out of control and new medications have been introduced, it may be prudent to watch that patient's blood sugar a little bit more carefully. Furthermore, if there are any concerns, you can surely consult your pharmacist. We'd be more than happy to help. Take a look at the patient's medications. And just to say, who's responsible? Whose responsibility is it to review medications? And this could be anybody, but primarily the nurse, the pharmacist, and the physician are key players in assessing patients' medication regimen. But don't forget that the patient and the family members are also very critical members on the healthcare team. So I wanted to introduce like a fictitious patient who comes to your clinic or comes to your caregiver care home, and she lives there, and her husband Johnny is with her. And um, she's been complaining that she's had pain in her lower back. She's been having back pain for several years, and she has pain in the lower part of her back, and the pain shoots down her legs. So a little bit of shooting pain. And she describes the pain as rather constant, very severe, and it just aches. It can feel like a little bit of a burning sensation. And the pain gets in the way of her ability to conduct her ADL. So she can't, she can't close, going to the bathroom becomes very difficult. It's just really cumbersome and it's getting in the way. So upon looking at her medications, she's on a bunch of different medications for pain, and we note that she's on ibuprofen, she's on Advil, she takes that quite a bit. She's on oxycodone, that's an opiate. She takes that 20 milligrams twice a day. She's also on a muscle relaxer, cyclobenzaprine, that's as she takes as needed for muscle spasms. She takes another muscle relaxer called carisoprodol, and she takes that every 8 hours. And she uses that when she feels that the cyclobenzaprine doesn't really work for her. But because she's in pain all the time, or she feels like she's in pain all the time, she can't sleep. So she takes Tylenol PM over the counter. Tylenol PM has Benadryl in it, diphenhydramine, and she takes that as needed for insomnia. And she takes that every single night. So she comes, and we realize that because of her pain, and she's ultimately having some side effects from her medications. That's where I'm going with this, is that these medications are causing her some side effects. These side effects include a decrease in her appetite. These side effects include she can't go to the bathroom. She's having constipation issues. She's having difficulty urinating as well. And because of this, she's not generally not feeling well. And so she's lost some weight over the past year because of the way her medications are making her feel. She doesn't really remember very much, but that's what she could remember. So we get a little bit more information from her husband Johnny, and Johnny says, "You know, she's very forgetful lately. She seems to cry a lot more when she's thinks that no one is looking. She's very confused. She's here in Hawaii, but she somehow thinks that she's back home in New York. And she often has hallucinations that they say that she has some crows in her room and she talks to them from time to time. And it's very concerning and it's very disturbing to him. So as you can see, many of these things or these symptoms that the patient and Johnny is describing um, is being caused by her medications. So we're thinking that the medications are helping, right? We gave her some pain medications. We gave her medications to help her sleep. We gave her medications to help with her back pain. It may or may not be helping in terms of those aspects, but it's causing a whole lot of other problems in the meantime with respects to uh, her depression, constipation, confusion, and whatnot. Here's some of her social history. She doesn't smoke, she doesn't have any alcohol, but she has some family that lives nearby and they can help with her ADLs. Um, she doesn't have a lot of money. She had some recent financial trouble. They used to live in a very nice house in on the Big Island in Waikoloa, but now they live in a studio apartment just outside town. And so in looking at her physical exam, the main thing that I wanted to highlight here is that she has some lower back issues, and it's really affecting her ability to walk. That's the basic thing here. And that when the physician looked at her, she was a little bit confused. And she's not having current hallucinations, but she's complained about it a little bit in the past. There are some lab values. So she went to the lab, got some blood work. And overall, everything is looking good. Everything's looking good. We were concerned about her lower back pain, so the doctor did an MRI, a little bit of imaging there, and we realized that she has some degenerative disc disorder. She does have some pathology there in her lower back. So there's reason for her having some chronic low back pain. So yes, she does have low back pain. So as pharmacists and as providers, some of the treatment goals for patients for patients with low back pain should be to reduce pain enough to allow for physical rehabilitation or prolong the need for surgery. So I'm not going to go into this is not a lower back pain lecture, but I wanted to use low back pain as a vignette, as an example of how medications can hurt, and especially if used inappropriately. So an appropriate use or appropriate way to treat her would be to use non-pharmacologic therapies at all possible, or maybe even if pharmacologic therapy or drug therapy is required. Um, Look here on the bottom under pharmacologic therapy. There are other medications that could have been safer. We could have chose better and safer medications for her. For example, maybe the ibuprofen was not such a great choice. The opiate, the oxycodone may not be such a great choice either. And maybe we can try to do some physical therapy. We could do Tylenol, for example, versus giving her all of those muscle relaxants that is making her have a difficulty to think and difficulty walking and using the bathroom at the same time. So as pharmacists and as clinicians, these are some of that we ought to consider when we are prescribing or giving medications. So there are some things to consider. So from a patient standpoint, we have to understand what other problems that they might have. Maybe they have diabetes, maybe they have kidney trouble, maybe they have heart trouble. And all of those different problems, medical problems, can really make the patient either more sensitive to these medications. We also have to understand whether the patient can take the medication or not. So we have to be aware of their adherence. We have to understand their physical limitations, their financial status. If patients cannot afford their medications, they can't take their medications. Um, and we also have to think about what are some drug interactions, for example, and making sure that the drug dosage is appropriate. So again, when we identify, so for our patient, for example, what should we do for that patient that had all of those medications that could be causing her problems? We should be deprescribing. We should be avoiding some of those dangerous medications like benzodiazepines, like Valium, morphine. We have to be very careful about our use of morphine. We have to be very careful or avoid using medications like Benadryl or diphenhydramine, for example, for sleep. Be very careful about using over-the-counter sleep medications because it can cause a lot of mental problems. In addition, muscle relaxants and certain antidepressants and antipsychotics can cause a lot of problems for our elderly patients. So if you identify or you see that an older adult takes one or more of these medications, I want you to consider discussing the concerns that the patient may have, maybe assess for some of these side effects like confusion, their ability to walk, maybe constipation, for example, and discuss this with the patient's caregiver, the patient's provider. Again, these medications or many medications can interfere with what matters to the patient. It can interfere with the patient's mentation, the way they think, being able to think clearly, affect their memory, and can also affect safe mobility, as it can increase their risk for confusion, delirium, causing them to be unsteady and even fall. Deprescribing is a method that includes both dose reduction and medication discontinuation as we work to clean up the patient's medication profile. So deprescribing is a patient-centered approach that we work together with the patient, the caregiver, and the prescriber to discontinue the medication in a very systematic fashion. It's not just discontinue the medication, stop it, and forget it. Deprescribing is a systematic method where we stop a medication and we want to make sure that we monitor because let's say you stop a high blood pressure medication. You know, If I stop a high blood pressure medication, I don't want to just stop it and forget it. If I'm going to stop the medication, I'm going to decrease the dose, monitor the blood pressure, monitor the heart rate, and see how they're doing. And making sure that I'm not worsening any condition as I stop the medication. And then when possible, we want to avoid prescribing these high-risk medications that I just mentioned a little bit earlier. And so that just really briefly concludes my presentation on medications. The one thing that I want to make sure that everybody understands is that there are certain medications that can be very, very dangerous for our elderly. And these are the medications that I listed here. These are the ones that are especially high risk. And those are your benzos, your opiates, your anticholinergic medications like diphenhydramine, all of your prescription over-the-counter sedatives, like over-the-counter sleep medications, like Benadryl, NyQuil, for example, Unisom. Muscle relaxants can be incredibly dangerous. Certain antidepressants and antipsychotics. So all of those above can be very dangerous for our elderly. But also, it is important to know that any medication can get in the way of mentation, mobility, and what matters for our patients. So we need to make sure that we take those into consideration and carefully monitor and assess the continued need for each of those medications, at least once per stay and periodically throughout their stay. At this time, I'm going to stop there and take any questions that you guys might have from the field. It's now, I just want to open it up to the field.
You have links in your PowerPoint? Would we have
Thank you,
access to
Dr.
that PowerPoint?
Kawakami.
Oh, sorry, I couldn't quite hear the initial comment. I apologize.
It's okay. You have links on your PowerPoint. Will we have access to that PowerPoint?
Yes, I think the PowerPoint is down. It was downloadable from the Echo website.
Oh, okay.
Is it right, John?
Yes, correct.
And I think the links work. If not, I can go ahead and send that to you.
I think if you just put a link to it in the chat, people can open it up.
Okay, yeah. I'll go ahead and do that.
Thank you.
Yeah. It might take me a minute to put them all in, but in the meantime, I'll try to multitask.
Oh, no, I mean, is your PowerPoint a Google Doc? Then you can just,
No, it's a PowerPoint presentation. Sorry.
that's okay then. I'll just go on the website. That's okay. Thank you for
Oh,
the
you know what? Sorry, it might not.
Dr. Kawakami, we have a question in the chat. My client is in his 50s and goes to dialysis and takes 2 tabs 4 times a day. I believe that's too much, but it is not over the daily dose of required amount to take Tylenol. Any suggestions? I already told the doctor, but he said he's alert and he chooses it.
So the question was, sorry. Patient goes to dialysis and takes Tylenol for pain. And what was the dose of Tylenol?
2 tabs 4 times a day.
So I guess I'm assuming that it's regular strength, not extra strength. Because regular strength is the 325 tabs.
Donna, do you know the dose of the Tylenol? Regular strength, she said.
Regular
500.
strength.
500 milligrams.
Oh, 500 milligrams, the extra strength. So the 500 milligrams, 2 tabs, 4 times a day is the maximum dose of 4 grams. That's the max dose. Huh. I would prefer, I don't like using 4 grams per day, all day, every day, on and on and on and on and on. I don't really like that. I think 4 grams a day for like a couple of days is okay, but for prolonged use, I would not recommend that. For prolonged use, 3 grams a day would probably be the safer bet. Um,
Yeah, but then he still chooses to take it. He's alert, but he
yeah, well, I mean, so I'm not so worried about the mentation in this aspect. I'm more worried about long-term use and his liver. So as long as we're monitoring his liver function, I would I would consider watching the liver.
yeah, he goes to dialysis as well.
Yeah, so a lot of dialysis patients are fairly frail, and the kidney has definitely been affected, but a lot of times it's all connected, and the liver. I don't want to affect his liver, because if the liver goes down, then we're going to be in a lot of trouble. So, I mean, is this the physician wants the 4 grams a day, or the patient?
The patients, because he's always complaining of pain, but which I think not, because he's faking it at times. But I mean, yeah, the physician was like okay with it. He approved it, and I did mention it before. I think he's just faking it, but
Yeah.
he's
How
still
about an
just for that.
alternative? Sometimes patients, hey, I'm a more is better. When I was a kid, more was better, right? So 2 tabs better than one, right? Straight up. But what if we did 2 tablets of the 325? So the regular strength Tylenol, so 325, and we can do 2 tablets of that. So that would be 650, and that would be under your 4 grams, and I would feel more comfortable. But and for all the patient cares knows it's 2 tablets.
Yeah, with my client, he's pretty. Oh boy,
That's sneaky, but I mean, you
yeah.
think you
I mean,
think it would make
yeah,
a
I can suggest it, but
just tell. I mean, he doesn't drink too, right?
no, it's just he had a history of substance abuse and opiates. Yeah, so
Yeah. Ah,
but I'll definitely suggest it to the doctor, if he'll be okay with that. But it's been mentioned before, but they just kept it the way it is.
right, right. Yeah, I'm not a fan of the 4 grams, the extra strength, 2 tabs, 4 times a day. I'm not a fan. Yeah.
That's a tough
Thank
one.
you.
You're welcome. Thanks for the question. I see a question in the chat. Thanks, Colleen. She said, if you had a patient with chronic back pain that takes morphine daily, what other medications could be recommended as alternatives? So I guess the patient is already on morphine. Um, so I said pain meds, opiates. There you go. Aside from morphine, doctor, you prescribe fentanyl hydromorphone. Okay, so those are really, really strong medications for chronic low back pain. And I guess studies have shown that, we probably don't want to reach for an opiate, such as those medications, for as long as possible. Um, Other medications that we may consider using for chronic low back pain include maybe gabapentin, um, or Lyrica, for example. Those are other medications that can help with the nerve pain that is associated with low back pain. That might be that is a consideration. So we call those co-analgesics, like Tylenol. You could consider gabapentin, Neurontin. Those are other considerations that we can go for before we just consider increasing the morphine dose.
And Angel had a good point in the chat to make sure that there's a bowel regimen because it makes our patients constipated. which you
Oh yes,
mentioned in your slide.
oh yes, 100%. Thanks for bringing that up. Yes, 100%. And speaking of constipation, not a big fan of not an incredibly big fan of Senna and Colace. I don't think it works very well. Um, if your patient can tolerate it, I'm a fan of Miralax. Yay, there you go, Miralax. Yes. I like Miralax. I think that it's relatively benign. Unless your patient is fluid restricted, right? Like if you have to watch that part. But if the patient's not fluid restricted, I like Miralax. You can't focus on Miralax because my students always are so concerned about giving too much Miralax, and I'm like, you know what, a Miralax over, yeah, it's called a colonoscopy prep. Yeah, and there's one that says Lyrica is only suited for nerve pain. Correct. A lot of times though, that chronic low back pain, especially if there's a degenerative component to it, can affect the nerve. And so it's that shooting, radiating pain, that the sharp shooting, radiating pain, that the Lyrica can help numb and dull down and turn down the volume on that pain. Yeah, fiber, prune juice, yeah, papaya, all of those things, 100% agree. I think when I used to work at the VA, every patient got a can of prune juice every single day. It's kind of like put it in the water, right? And what about lactulose? Lactulose is okay. I'm okay with lactulose, but people don't like the taste. It's so thick, it's so sweet that it's very difficult to drink. So I think exactly, yeah. So Angel was like, yeah, the lactulose sometimes with the elderly not compliant because of the taste. That's the big thing. That's the big thing. So the Miralax, you can kind of like you can spike their drink. Has no taste. It's colorless. So just throw it in some water for them. Um And Miralax not good if the patient is on a thickener. Yeah, that's true. That can be true. Yeah. So Miralax not for everybody, but for the majority, I think you can get by with Miralax. Um, so Donna said he takes it after dialysis with the Tylenol. Is that okay? Sorry, what? I missed the oh did he take the Lyrica after dialysis? Sorry, Donna.
Donna was the one that was talking about the Tylenol earlier with her dialysis patient
Oh,
that was
yeah,
taking
yeah.
the 4 grams.
So he takes it after dialysis with the Tylenol. So Lyrica and Tylenol is okay after dialysis. And it's good that he takes it after dialysis because the Lyrica, if he takes the Lyrica before the dialysis is going to remove all of the Lyrica. It's going to pull it away. So yeah, he should take that after. And I had another question with Carolyn. Carolyn said, if the resident is already on gabapentin 2 caps daily for chronic shoulder pain, can she also have Tylenol on top of the gabapentin, same time or hours apart? Thank you for that question. And I really like the thought process on there because there are certain medications that you cannot give or you shouldn't give together. But in this case, and the same case with the Lyrica and the Tylenol. Yeah, you can give the gabapentin together with Tylenol. It's okay. Same time is fine. If you give it hours apart, that's fine too. But for simplicity, you can just give it together. That's a great question.
Oh, you got a long question in there from Emma. In a
Okay, hey,
nursing home, we do have pharmacists who review meds monthly and give their recommendations. For care home settings, how often can we do pharmacy consult, and how should we know medications that need monitoring of labs, especially for medication on long-term use?
Ooh, that is a hard one. Yeah, because for nursing homes, they have contracts with consultant pharmacists, but for care homes, typically do not. Um, I think the closest that we could do for care home would be it's not a great answer. That's a hole. That is definitely a hole in terms of um pharmacy oversight. I think you kind of got me there. There are certain areas of care that pharmacists haven't really aren't readily available to provide consultation. I think care home is one of them. The others may be like, community dwelling, senior care, senior centers, some assisted living, those are holes. Which brings me to a good point of maybe that is something that pharmacists as a profession we need to kind of look into. And there are some pharmacies that will do a quarterly review for a small fee. That is true. Smaller retail pharmacies might be able to do that. You might be able to consult your community pharmacist, but for the majority, there's really not a lot out there. Don't all pharmacies, then the other question was, don't all pharmacies provide drug information? And all pharmacies do provide drug information. The doctor's offices does as well. But the problem that I have with, and this is the system, right? It's not like a pharmacy or a doctor's office. It's the system. It's so disjointed. So if a patient goes, say, I get some medications from CVS, some from Time, some for Safeway. Excuse me. The patient medication profile can be a little bit jumbled up, and the pharmacist can't see the complete picture. So, it's difficult. It can be difficult sometimes to really get a full appreciation of what the patient's on in totality. But certainly for each individual drug, you can get that information through consultation with your community pharmacist. They should be able to answer your questions. Like, for example, like they should be able to answer the question of, like, if you had the question of Tylenol and gabapentin, they can provide you an answer. They should be able to provide you an answer there. Yeah, and I got another question. It's like maybe they can cater more for more populations in a facility versus care homes. Review meds for care home operators request for a fee. That is a great idea. Yeah, you could call your local pharmacies. They'll probably be able to help you. For me personally, when I call, if my recommendation is if you're calling a community pharmacy, sometimes the smaller pharmacies are a little bit, may be able to give you a little bit more customized attention. So for example, like your small mom and pop stores or the Times pharmacies, the less busy pharmacies, those might be able to help you a lot better. It's like me going into a hardware store. Like sometimes I don't know what I want, and then I go into like Home Depot. Nobody can help me at Home Depot. But if I really want help, if I go to like an Ace Hardware or City Mill, they can really explain to me like, oh, this is what you should do. I recommend this product. So it's that same feel, like the smaller local businesses might be able to give you a little bit more attention versus the large chains. I like Costco. I used to work there. Got a lot of friends there. I think Costco is a good pharmacy to work at, to ask to. And they got the resources as well. But yeah, I like the comment about, care home pharmacies and care homes for a fee. I think that we would like to lean that way. There's a couple of legislative bills that we're trying to pass as pharmacists to be able to be to charge insurance, to bill insurance for our fees. And I think if we can bill insurances for our fees, then some of you, if your clients have insurance, we can bill insurance and get paid for our services. And that would really open the door for this hole that we've just identified in pharmaceutical care oversight.
Thank you, Dr. Kawakami. Is anybody else?
Just call me Chad, by the way, not Dr. Kaw. Just Chad's good.
Oh, we have one from Layla for the CCFFH caregivers for the foster Whereas the CCMA RN visits monthly and the RN should be reviewing the meds. That's true, Layla.
Yes,
Part of
yes,
their assessment.
yes.
Yes, Brittany, I was just about to say that for adult foster home and CCFHs, the agency that they're under, by standard, the nurse should be at least doing a quarterly check. Because,
Yeah.
I do mine's quarterly when I go do their home visit. So,
Yeah.
and then they do some pharmacy, they do, if you have questions, they do answer you. But usually the doctors, you can also ask also. Some are more willing to help out than others.
Yeah, and now that you mentioned that, like that's like maybe that's a potential future model where you have like one pharmacist per, I don't know, pick a number, like 10 nurses, and we could that pharmacist could serve as a consultant for that panel of nurses when you have concerns, right? Because I think for the run-of-the-mill patient, you look at the meds and you're like, yeah, you're fine, right? But then every now and then you come up with you see a patient that's like, oh my gosh, it looks like I don't know, I don't know what kind of recipe this is, but there's like 10, 12, 13 different meds, and can you help me untangle this mess? I think that could be a potential point of collaboration. But that's good to know, because I think that from what I'm gathering here is that there is a need and something that we can look towards building in the future. And yeah, some PCPs, I even for pharmacists, like, some PCPs, like I'll have a question or, I have a concern, and some PCPs are very receptive, and then other PCPs won't even give you the time of day.
And Aurora had a question. 92-year-old female always yelling for no reason. Is it safe to treat her with risperidone?
So, that's difficult to answer, but I'm gonna this is kind of my take just based on what I'm seeing there. So always yelling for no reason, is it safe to treat her with risperidone? Usually when we medicate someone for agitation, we're medicating them for a specific reason, and that's because non-pharmacologic methods have failed, and we're not able to like redirect, or redirect, for example. If the patient is a harm to self or others, then sometimes pharmacologic treatment is appropriate. But if she's just yelling and being noisy, and for lack of a better politically correct term, just being obnoxious, that's not really a great reason to medicate, because the risperidone can cause side effects in terms of cardiac arrhythmias. So there's a warning that it can actually harm them, and actually hurt them, and cause cardiac arrhythmias, and that's a warning that we need to be aware of. So it's not as benign as we like to think. So short answer to that question is it safe to treat her with risperidone? The answer is really no. So if she becomes combative, would risperidone be considered? I would say yes. So like if she's hitting people, like if she's just swearing at you, that to me, that's not a good reason. She's not hurting anybody. But if she's swinging at you, she's being combative, she's at risk for herself. Because if she swings at you and she misses, she might fall and hurt herself. That's bad. And if she's hurting you or hurting the staff, then that's bad too. And that might be risperidone might be considered. But before I reach for the risperidone, excuse me. Before I reach for the risperidone, I would reach for like non-pharmacologic things as well. So like, try to de-escalate, redirect, try those methods first. Pharmacologic therapy is going to be your last line.
Does anybody else have any more questions before we wrap up?
Hey, thank you guys so much. I really appreciate all of these questions. Are super, super great questions.
Thank you for presenting. We've learned a lot, especially with the 4 M's and what matters, and medications and mentation and mobility. it's good to know.
Yes. We want our medications to help and not harm. Unfortunately, sometimes they do harm, and that's when we need to be aware and take action. Other than that, thank you so much, everybody, for chiming in, for all of your questions. That warms my heart because I know that we all have our patients' best interests at heart, at the center of everything that we're doing. And it's super wonderful that you guys are all here. Thank you so much.
Hand it over to you, Annette or Leila.
Well, I wanted
Thank you.
Yes, thank you so much for doing such a great job on the presentation today. We appreciate all of the Hub team, and we're looking forward to next month's presentation. Everybody have a great day. Thank you so much.
Thank you, Dr.
everyone.
Kawakami, for that
Thank you, Kat. That was great.
presentation. Just a reminder to please don't forget to complete the evaluation. The link to the evaluation should be in the chat. In order for you to receive your certificate of attendance, please complete the evaluation, one per person who attended. If you join as a group, each person need to complete the evaluation. For those that are seeking CMEs, please complete the evaluation as well, and you will be receiving your certificate in the middle of December. And please make sure that we have your correct email addresses and the spelling of your names. Thank you so much for attending today, and thank you for all that you do for our patients. Have a great day.
Thank
Thank you.
you.
Mahalo and aloha.